mute button. It might be Andre, actually, is something. Okay, hi everyone. We're going to kick off right now once I work out how to share my screen. Just as, let me share my screen. Once I start sharing my screen, I won't be able to see anything though. So I will rely on everyone to shout and scream at me. Anyone who knows me or has been on any session I've had before, how do I do this? I've got to move you. Knows that for a session like this, what we're really aiming for is a very closed group discussion. I'm going to provide some key tools and tips given the challenges that we're facing, and you guys be very candid on either good practice that you're learning, challenges that you're facing, support that you need, or what we can do for each other. So just before we get online, I'm just going to say with me today, I have Nurian from Save the Children. She is co-chair of our GHC Quality Task Team. She was also co-chair, co-writer of a lot of the COVID-19 guidance that came out when we were facing incredible challenges as clusters. So she is here today to give partner perspective, and we'll give her a couple of minutes later on so we remind ourselves what our function is as health clusters. Also, I've got Andre Griekspoor with me, I believe he's joined, who was previously in the FCV department. He is here sharing his knowledge and expertise. He's been critical in developing a lot of the previous guidance that we've written and working with you all in various ways. And I believe, John, are you here as well?
I'm here.
I can't tell. I am, great. Who, if any of you have been part of the H3 webinars, how to develop a package, an essential package, he is the key creator of this and manages the website and is from UHC, Primary Healthcare Services Unit. Okay, so the point of today is we're really looking about this issue around managing dilemmas and prioritize, I can't say this word, responses. Someone has to make sure that people are saying hi in the chat and explaining who they are. Because we just want everyone to be one big family at the end of the day and make sure this is a safe space where we can openly discuss. Okay, so the purpose of today is to really just help you as you support your engagement with partners. A reminder that the health cluster is a service really to support all partners to deliver on humanitarian response. So we know that currently we are facing an unprecedented crisis. We're having to make difficult decisions. Partners are having to make decisions, prioritizing, withdrawing, and we know this has an impact on populations. This webinar is for anyone within the health cluster team, definitely the cluster coordinators, whether it's national, subnational, because all of you are engaged with partners. Some of you at the national level are dealing with prioritization processes, the HRP revision. We're not really going to touch on that today. We're going to provide a bigger framework on how we ethically go forward and some of the key questions you should be asking. But at subnational level, we know that operationally you are dealing with partners. So today, unfortunately, we do not have solutions because the situation is dire, but we do have a framework to work with. And we've got a lot of learning from this, from COVID-19, from other crises, where we really cannot fulfill our mandate and reach all populations of concern. Not populations, then populations in need. So a reminder, current context. For this year, prior to this bonanza, this fiasco since January, our people in need from all across our settings is 164 million, and we're aiming to target 75 million. This is prior to any prioritization processes that you may have already kicked off. We're around in 26 settings, mainly because last year it was 29. Madagascar has deactivated. Whole of Syria is combining into Syria. We have officially over 900 partners, most of which are local and national actors. So the impact of the funding freeze, I'm sure all of you have seen or have been part of the OCHA survey that went out. They're doing two, but this is preliminary results from the first one. It's nothing surprising. I'm sure you've got country-specific data as well, but across all crises, about nearly 50% of funding was from the US. The biggest impact is really, since the suspension, is around decrease in geographical coverage and also a reduction in capacity of workers. We have a breakdown of other things. If you've not seen this, you'll get these slides, so I'm not going to walk through it now, but we know that this has a huge detriment to our operations. From the survey that you guys have been reporting in on, and thank you so much. Every day we get something new, but this is as of 10th of March. We had reporting from 12 countries, and even just from 12 settings, we know that 23 million people are affected, over 2,500 health facilities, lots of primary healthcare facilities, but also lots of hospitals as well, whether it's suspended or reduced services. So this has a very, considering our PIN is 165 and our people targeted is about 70, already we see a huge amount of people who are affected by this suspension. So what does this mean? Lots of things. Number one, I know you're all going through prioritization because we just cannot cope. We do not have money from other donors. We discussed this last week with Altaf and Linda in our webinar, just to say there's a new statement from the ERC that's now public. It's online. The link is here. You'll get that later, or you can Google it. It's on the ISC website. We have to support and get partners to support funding, SURF and CBPF, to quickly get money out. We need to do the revision of humanitarian strategies. Lots of you are already reprioritizing, whatever that looks like in country. That is up to you. The EDGs are creating a prioritization plan, but obviously OCHA at country level, as we discussed last week, and as we've already seen in countries like South Sudan, Yemen, other places, you're focusing on intersectoral severity 4 and 5 and not 3. Reduce the number of humanitarian response plans, meaning clusters will be deactivated, etc., etc. Clear in his statement, however, sorry, someone got a question? No, okay, cool. Veronica,
no,
okay, Veronica and Nurayan, I'll count on you to let me know, because I can't see the chat box. I'm in my own little chamber here.
Yeah, I'm monitoring it, so no worries.
Thank you. Okay, so clear within his statement, and it's online, and it's in one of the last paragraphs, is that cluster coordination and the role is essential to ensure that we have discussions about prioritization that represent the totality of cluster membership. We represent everyone. We have no bias. We are neutral. We don't do operations. We do the intelligence gathering and bring everyone together. So our job is very clearly articulated there. So I am just going to stop so I can see people. I'm going to invite, just for a couple of minutes, Nurayan to explain or describe how Save the Children is, what the challenges they are facing, the reductions they are having to do, and what impact this means. And then also to hear from her, just briefly, some requests of what she needs from health clusters to either scale down, innovate, adapt, or withdraw completely. So this is from a partner perspective. And I'm very grateful for Nurayan, because it's extremely, as I'm sure with all your partners, you know, it's very sensitive. So thank you, Nurayan, for being here and being willing to share openly with our cluster coordinators. This is a safe space for you. Over to you, Nurayan.
Thanks, Eva. Good morning, everyone, and thank you for inviting me to come and share what Save the Children is facing and what we have been doing so far. For sure, like everybody else, I think this what is happening, I think we can categorize it as a Cat 1 emergency globally. Everybody is facing challenges. As you know, Save the Children works in both development and humanitarian settings. So with this funding freeze or the change, the executive order, both our development and humanitarian programs have been affected heavily. I would say compared to development programs, humanitarian programs are less affected because they can be sort of like categorized as life-saving. But having said that, we have received the termination notice for most of our BHA awards with some waiver for certain countries. So it's not like all the countries have terminated all the humanitarian health programming, but certain countries have kept it under special approval. But majority of our health programming, both in the humanitarian and development settings, are impacted. So as of now, up to now, what we have been trying to do is looking at all the BHA funded health activities and see who are the other donors we have and working in the same area, and also check with the donor if they are flexible enough for us to sort of like look at proposed activities and categorize them as a life-saving and not life-saving. So use the money we have from other donors like ECHO, FCDO, and other some private donors to see if we can use it to cover the areas covered under BHA funding. But of course, this is the case in some countries and some regions in the country. But we also need to close down not all, but great percentage of our health programming, I would say, because we are unable to hand over it to either cover it is with our existing funding or hand over it to either Ministry of Health or other health partners. We understand everybody is facing same challenges. So, I mean, for Save the Children, we do have very strong fundraising capacity, but because this is, as I said earlier, this can be categorized like Cat 1 and everybody is facing exact same challenges, and we all need extra funding to cover the areas US government funding have been covering in the past. So it's a sort of like situations that, you know, even with a strong fundraising capacity, we are unable to carry everything forward as if nothing happened. So we are reducing our interventions. So as I said, for the activity, for the closing BHA awards, so like one, we are trying to cover it with the other existing health funding, and then we also have some humanitarian fund we can request, and that is another mechanism we are using. And then the other options to look at who are the other health partners in a similar area and if they can take on, and then also coordinating with the Ministry of Health to see if they can keep the services open at lowest capacity while we are looking at other funding options, and if that is not possible, closing down the programming. Of course, we have started the communication with the communities, with our local partners, and of course with the suppliers, with the staff, like from early on. So we could not say we want to close down the health programming ethically, because there is nothing ethical about it. You people are getting health services, and then all of a sudden they're not going to have any services. So we are trying to say, okay, how can we either close down or hand over or cover the essential health, life-saving essential health services in the best possible way in the given context. That is what we have been trying to do. And so like 2 weeks ago, yes.
Sorry, we've got to move on a bit.
Sorry.
No, it's okay. It's quite, it's devastating, obviously, hearing this. Can I just ask that you give an idea of perhaps some countries where you know it's severely affected, where you may be closing down some facilities, but also and what you need from the health cluster? Just 60 seconds on that, please.
List of countries. I like Somalia could be one of them, because we had a huge BHA funded programming. We were supporting over 100 health facilities, and many MOH staff receiving incentives from the BHA funding. And of course, we also have hired many different people with different function. So at the moment, we are trying to fundraise to cover some portion of it, but we won't be able to continue with that scale. So, the facilities need to close down. So we have looked at the catchment area, and then smallest area by possible, to see who are the other health actors, what can be done collectively. So I think for health cluster, I'm sure all the health cluster coordinators have been doing the exact same. You look at who is doing what and where, and see who is impacted, who is not, and what are the other funding source we have in a similar geographic area, to see if it is possible for us to cover life-saving interventions in one way or another. I think that is the coordination and bringing people together, looking at the resources and utilizing resources well. I think that is what we expect from health cluster, and I'm sure this is what all the cluster coordinators have been doing. Yeah. Over.
Talking to myself. Off mute now. Thanks so much, Nurian. That's a very open update that you've given, and I think just reiterates, number one, the importance of everyone who has joined this call today, and anyone within the cluster team, to enable partners to respond and reach the most. So I'm just going to go now
if I may say one more thing, sorry.
Sure.
So in terms of fundraising, our effort, of course, from last week of January, was more focused on talking to the, I guess, bigger donors, and the donors with the bigger envelope, and then also we have high value, high net individuals who can donate 50 or more than $10 million. So we have been trying to coordinate with them at the early stage. And then we started coordinating with the private sector. But now we moved on to smaller donors. So we have developed different concept notes for different countries and different thematic area, to see who might be able to cover what, so we can sort of patch everything together. That is our focus at the moment. Over.
Okay, that's great. I mean, I think that really highlights as well how the situation's fluctuating, and as people are trying to, and partners are trying to get solutions, whether it's for 1 month or 2 months or more than that. Okay, so guys, we're going to move on to a tool, guidance that was developed during COVID-19. It's really around supporting you and supporting partners on how to manage or deal with dilemmas. Okay, so what is a dilemma? It basically means when a situation is terrible and all options available to you are bad. So there is no good solution where you can say, oh yeah, that's obviously right. Save the Children is closing down, or WHO is closing down. We can hand over to XYZ. It's fine. Or it's not the best, but it's okay. When you're in a dilemma, it's when all the options available to you really do create some kind of severe inequity or even harm. And we deal with this all the time. Some examples that we all deal with, for example, in COVID-19, when we didn't have oxygen in facilities, who should get it? You've got 3 people waiting, an old person, a middle-aged person, a young person. Should it be the first person who arrives at the health facility who gets the limited amount of oxygen that's available? Or should it be the young person because they've got a better life expectancy? The older person has got comorbidities. This is a dilemma at the health facility level. That actually was happening in Yemen, for example. We had multiple reports on that. Curfews. This is actually a dilemma because you're forcing people to not go out, not move, and you're depriving them basically of a very simple human right. We face this all the time when we haven't got good quality health facilities. We might not have enough WASH or IPC, for example, in a secondary healthcare facility that's providing trauma care. What do? Do you close it down, or do you fingers crossed and hope you do it? Earthquakes, we see huge amounts of amputations being done. Should it be done, given that we don't have sterile procedures necessarily? Addressing traditional harmful practices. This used to be a bigger deal, a big dilemma. A lot of 15 years ago, humanitarian partners, practitioners, even in high-income countries, just in the schools, were very fearful of addressing this because it's a person's right to believe and to have their own cultural beliefs. So when is that harmful? And when do we have the right to intervene? I'm trying to click closing down markets. And then one that obviously you guys are dealing with now, and our partners are having to suspend humanitarian programs or services. Okay, so right now you are having to deal with populations to prioritize, perhaps which services or response to prioritize. I don't know. We've seen guidance come out saying you can only do SO1 only. Some of your SO2s are around outbreak, preparedness, surveillance. Are you going to suspend that? What actions will you prioritize within this HRP revision? And then ultimately, you're deciding which populations should not be allowed or will not be prioritized to receive life-saving assistance. So this is pretty dire and pretty terrible. But something that we deal with all the time. So what is ethics? I don't want to go into jargon. It's, people say, oh, ethics, and we need to think about ethics. Essentially, all it is a bunch of concepts or standards or whatever it is to help us, anyone, do the right thing and make the right action. What the right action is up for debate. And that is purely subjective. Ideally, we'll agree on some common principles and values. It's something that's been happening for hundreds of years. It's not invented with the UN or humanitarian principles. It's been going back thousands of years. And like I said, there's not one right concept. So this is really important because we need to come to a kind of consensus. But what's really useful is that it helps us make these terrible decisions when you're going to deprive someone of services or create harm, that as you make those decisions, you're doing it in the right way. And so this is the important bit because this will help you as cluster coordinators face this awful situation, but also your partners. Okay, so why do we need to do it in the right way? Why do we need like a tool or just like a quick checklist? Well, number one, to maintain trust. We are here to support affected populations. They're going to be seeing clinics close down or disappear or suddenly not have people around. Already we work in contexts where public trust is critical and essential. If you do not have that, you are not a very good provider, and it's part of our commitments around AAP. We have to make sure that decisions are not just made by one person individually, that we've got some kind of common understanding and agreement. It's not ad hoc. It's not, oh, the nurse in the healthcare center is suddenly going to say, oh, you're going to have oxygen, you're not. Or for subnationally, some cluster coordinator or some partners saying, we're going to close down here, we don't care about anything else. Whatever it is, it's to ensure that we get some kind of consistency around this so that we can be transparent. But also we need to be trying to engage with communities around this, not just around communicating with them, but understanding what their perceptions are. And of course, to make sure that all our frontline workers are supported, or partners, or us even, and we're not unduly burdened by this. So this tool was developed during COVID-19, importantly with Sphere, with the Global Protection Cluster, with the MHPSS reference group, with the ethics group, and with READY, which does a lot of work on did a lot of work on outbreaks in humanitarian settings. So this was really using existing commitments from the core humanitarian standards, from IASC, from protection mainstreaming, etc., etc. So we're all in line here, and you will find this guidance on their websites too. Okay, I'm just going to quickly talk about some of these standards. It is jargon. I'm not going to go through much of it, but just to say, this jargon is stuff that you know anyway. So we talk about justice in ethics. That means equity. Everyone has a right to resources, opportunities, the best outcomes, the best health outcome, regardless of their vulnerability. It doesn't matter if they're an old person, someone living with disabilities, someone living with mental health conditions. But also justice means this procedural way of being fair in the process. When you make, we've talked about this, when you're making a terrible decision, what's the fair way, open way of doing it? Beneficence, we talk about, that just means the humanitarian imperative to help people. Don't do harm. Liberty is essentially your human rights. Respect for persons, having a people-centered approach, understanding their values, their preferences. And this is the big one, which we are faced with, is utility. When you try to reach as many people as you can in the most efficient way, but may mean that you're actually depriving people of the individual. By doing the most life-saving services or critical services, you're depriving others from some other ones as the services that may be essential. So our current challenge is trying to reach as many people versus withdrawing. But also by withdrawing, we're creating harm and we're unable to help people. Okay, so blah, 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 blah. Let's get to the tool. It's just very simple. A few questions to ask yourself as you're having your conversations with your partners at subnational and national level. I'll just walk through it here. Why do we do that? We've already said this. The process itself needs to be transparent. Let's go through it. Is it an ethical dilemma? Do you have any good solutions? If you do, then it's not a dilemma, and you're hooray. But what are the pros and cons of all the bad options that you're facing, that you've got? What are the ethical principles or the humanitarian principles that are being challenged or diminished? Why are you making? What's the rationale behind this? Is it because you want to protect your job, you want to protect your staff, or is it because you want to protect services for people? The last one is a really important one. What's your own bias compared to that of the community? Who's having to deal with this? Is it everyone? Is it just a few people? Is it just Ministry of Health? That's an easy one. Who is affected? Are some groups affected more than the other? Which ones? Is it IDPs who are going to lose out? Is it IDPs in host communities that are going to lose out because they're in severity category 3? Which ones? Understand that. And then importantly, what's the community perception of this? Are they bothered the way we're bothered? Are they even able to engage in this? Do we know what their priorities are? What do they think about the different response options? And this is where your partners really have a role to ensure that communication. As health cluster coordinators, we rarely get to the population, but our partners do. They are part of the community social network. So what do they think about that? And do they have trust? Is their trust eroded by this? Or will they be empowered by this? Is it different? So it's really important to get that population preference understood. And this is something you need to gauge with your partners. And then going forward, okay, so how do you address this, or how do you come up with a choice? Who should be involved within the organization, other partners, Ministry of Health, local partners, HCT, communities? At the very least, how are you going to create this process? You have to create an environment. This is really critical on the health cluster coordinators, any level, is you have to create the environment to openly and safely discuss this horrible dilemma. And many of you are already doing that. I can see the emails flying around on health cluster meetings, discussing the current situation. But you need that trust from your partners to openly say, listen, I may be pulling out in 1 week. I cannot do anything else, you know, and without name, shame, there's always better ways of doing it. But if they really don't have any solutions, we need to be able to be working with them so we can, at the very least, understand what that gap is. And then also, you know, we have a role as cluster for advocacy. So just do a stop check at any point to, you know, understand who's being affected or not, and where you can find more information like protection risk assessments. And then you collectively, in that safe space, try and determine an appropriate response, a working group, something or other. I'm sure people are doing that. I know clusters are doing it right now with regard to the HPC revision, but at a subnational level, what, you know, where can you map out which facilities you think are going to go, who can take it over, who can take on the MOH incentives? Can MOH be okay and survive without that or not? So all of that, again, include those communities, especially through the partners. Collectively review the situation, do your pros and cons, and be honest about the impact. And then for those who are going to lose out, think about those mitigation measures. And I'm pretty sure most of you are doing this already, which is great. This is just a checklist for you to make sure. And then what's your next steps? You have those SOPs, you have those agreements that needs dissemination, ensure the advocacy, engage with communities, make sure they are aware of what the future is or what the step will be, whether it's withdrawal or suspension of services. They actually have a right to feedback through AAP and challenging decisions. And if you look at the ERC statement from DUDA, Tom Fletcher, that I've shared, I'll share the link later. It actually says we will step up our IASC collective AAP mechanisms, feedback mechanisms, because it's absolutely critical that populations still are able to feedback if, number one, they're losing services or other issues. And then it's a very distressing time for frontline workers, for yourselves, for partners. So, you know, there's MHPSS support that really should be given around that within the organisation duty of care, and reviewing the dilemma as possible. Now, I know this is hard because a lot of us, including myself, aren't even sure if we're going to have a contract next month. That's myself as well. At HQ, for example, we are on 1 month extensions, if that. So I'm waiting to see if I get extended for 1 month. But this is the work that we do, and this is how we have to get forward. So it's doubly hard because we're facing our own stresses as well, but we have a role to play. Again, create the environment, collaborative discuss. Try and think of your resources and capacities, and we'll go through that in a minute. Supporting frontline workers and making sure we have advocacy. Okay, I'm just going to stop there for a minute. See, oh, great, thank you. Does anyone have any thoughts, comments at this point? It's a bit depressing, but I know many of you are already doing part of these inherently, whether you know it or not. But does anyone have any comments at this point? Have I depressed everyone? I cannot see hands up. Okay.
Iba, if I may say something just for 1 minute.
Please do. Yeah.
I think the whole situation is very depressing and devastating. And I think all of us have very tough, going through a tough situation, like, like I know the cluster coordinators, from cluster coordinators, sub-cluster coordinators, and of course our communities affected. I feel like among those meeting participants, I think sub-cluster coordinators have a tougher job among all of us. Because for us, yes, we can provide you with a guide, but you are very close to the people we serve. You in the collaboration, you need to coordinate with the health partners, MOH, to say, okay, which health facilities need to be closed and which services need to be sort of like scaled back. So I think the sub-national cluster coordinators have a very tough job among all of us. I mean, there are like guidance and different ways to work through it, but like every situation, every country, every region is different. So I think the principles, the questions Iba presented is just a key reminder for us to say, okay, I need to do this, but those are things I can keep in mind when I'm doing it. I just want to say, like, we understand the situation is difficult and you are facing even bigger burdens than me, for example. Over.
Thanks, Marianne. Does anyone have any comments so far? If not, Galina, you're on video, so I'm just gonna ask, did you want to say anything? And welcome, by the way. I do pick on people, but I don't mean pick. I encourage, I probe.
Well, maybe I'm not the best person from Ukraine health cluster to talk about the situation, just because I'm in charge of attacks on healthcare. However, it affects, of course, also more, as Norian told, that actually the most affected are subcluster coordinators who have the most of the tasks today, just to negotiate what is the most essential, what is the life saving, and actually in what way actually we should go on. Thank you.
Thanks.
But it seems to me, from the ethical perspective, maybe just because I looked from the perspective of the clinical ethical principles, maybe we do lack also autonomy of once one my colleague actually criticized the word beneficiaries. Actually, she told that actually we do not take into account actually their autonomy. So as you started with the concept of the informed, to inform our colleagues and communities and the Ministry of Health, so also to engage them more in the decision making, and not, but actually to look together on the decision making. Thank you.
Thank you. Okay, a comment from Samer, and then Eric Didier. I saw your hand go up and then it went down, but I will call on you. Samer, hi, Samer.
Hey.
Good to see you again.
Thanks. No, just to maybe to put a bit of positivism in the discussion, because personally I felt a bit depressed over the past 40 minutes. Sorry. Yeah, I mean, but on a positive note, that for example, we are expecting ECHO first, let's say, allocation of the year to be released soon, if it's not released in all the countries, which potentially might absorb some of the gaps or even cover some of the priority areas that we will, in every country, let's say, agree where to put it. In some countries also, there's the first standard allocation of the SURF funding, like the UHF in Ukraine, Ukrainian Humanitarian Fund. I'm sure it also in other countries. They have just put $100 million to 10 neglected or most neglected crises globally recently. FCDO is opening a call, at least I'm aware of the one in Ukraine, for 10 millions at least, and they're asking and pushing for localization to be very strongly considered in this call. The Norwegians are also increasing a bit their funding in different places. So, I mean, my point here is not about how many millions we lost and how many millions we can recover. It's more about when we are putting the things, we need also to maybe balance it a bit. It's not just a black, it's a shade of gray. While over the past 40 minutes, I got it more towards the black color. And I think it's also something that we do the same with our partners. We do the same with our Department of Health when we meet. And as part even of the self-care and taking care of ourselves, I think we need always to remind ourselves that there's also something coming. It's not enough. It's not 100% of what we lost, but a bit of balance, not to get so much down over.
Yeah. Also, just saying there are some favorite crises amongst donors. FCDO is actually halving its ODA, its amount. And so they have 6 countries that they are very, very focused on: Sudan, Ukraine, possibly OPT. And so that's a whole other conversation, but they're already reducing their funding. And so is Canada, so is Germany, so is Sweden. So it is a lot that we have to do. And every situation is unique. I'm painting a bleak picture because we need to anticipate that. You may be in a fortunate country where political attention is still there. We have others where it's not. And so we've just got to be and make sure we've got the tools to deal with that. And whether or not it's this situation or another, there will be something, whether or not you can get access, provide healthcare services on the front line, on the contact line, or whatever it is in different countries, conflicts. We face ethical challenges all the time. So we just need to make sure that we're thinking about it. Eric Didier, over to you. Were you going to say something?
Okay. Thank you. So, well, I agree with you guys about the fact that is a very devastating and stressing situation. And what is coming to my mind is like we are going through what the people we serve are going through too. So at some point, we need also to recall ourselves that if we are working in this field, it's because we believe in hope. So we are giving hope to people we serve. So we need to give hope to ourselves. It's a very tough situation, and it's happened. It's happened to people who we serve, and now it's our turn. But because we are hope for others, we need to strongly believe that there's still a window for hope. And this time will, it's now happened, but maybe in a year, I don't know, but this will go away. Anyhow, we just need to be strong, to resist, to stand for our value, for what we believe in it, to work hard. This is where now we need to reinvent ourselves, to go out the box, because at some point we just rely on one donors, and not to blame ourselves, but it's a mea culpa. That's it's somehow our fault. We should have anticipated and keep the industry, the independency of our industry. but is not the end of the industry. So I think that there is a hope, and we need to be strong. Thank you.
Okay, thanks, Eric Didier. And I like the point that you have around innovation and adaptation, whether it's about funding or whether it's about programming. So I'm just going to quickly go through this health services prioritization tool that was also developed during COVID. With 30 partners, including WHO, multiple units. We have Andre and John online. We have developed the H3 since then, the minimum package that should be developed, rolled out in humanitarian settings. But this is a tool. It may not be completely appropriate for what you're doing, considering you're giving geographical prioritization or even just funding prioritization, but something to help you think about as you go forward, because I know some of these terms have been used around life-saving. Again, so it's helps us determine what we can temporarily suspend, adapt, continue, or what we need to protect. General principles around this has been safe service delivery. Whatever you do, whatever remains or whatever is adapted needs to be safe both for yourselves and for the service provider. Very valid in insecure contexts or otherwise. And if your catchment population, whoever you're handing over, suddenly increases. Community engagement, we've talked about. Coordination, we've talked about. An integrated approach, including other sectors. So number one, we need to be thinking about health threats across the life course when we're thinking about the biggest life-saving services. But also in our adaptations, there are resources, partners in other clusters. Is there, or working in other clusters, nutrition or WASH, are there ways to increase efficiencies? Again, making sure we think about the totality of our affected population, all the different at-risk groups, and making sure we have an ethical approach. So those are basic things. This is very simple. I won't really go into it, but the first thing, this is the algorithm that was kind of developed, is around understanding the health needs situation. So, what are the health risks, health threats? You will have a PHSA. What's the health system? How are they being financed? Is it Save the Children providing incentives? Is it WHO and UNICEF providing incentives? Is it others? Understand what the reality is, the political context, the trust in services, and the barriers that they face already to receive services. Do some segments of the population already suffer inequity? Then what people are doing is really trying to understand what's the most, what addresses the most urgent needs. So when we're looking at a set of services, we're looking at priority services, and this is like the H3. This is when you can't even do the H3. What is the most urgent? As in, if you cease to provide that service, will cause mortality and morbidity already, where it is incredibly time sensitive and any disruption will cause harm. Life sustaining tends to be, we described it in line with SURF and others, is contributes to health outcomes, but temporary suspension may not result in immediate loss of life or psychological harm or morbidity. I'm going to put things like, what can I put in there? I don't know, maybe routine vaccination is up for consideration there. Maybe surveillance is up for consideration there. These are questions. And services that need to be protected. So they may not really have any impact on mortality or morbidity, but are really critical to ensure we help populations affected by a crisis recover from our harm. So we're really thinking about things like clinical management of rape, or psychological support, accessible care for people with disabilities. So this is a kind of triage way of looking at it if you're going beyond and you cannot meet the H3. When you're looking at revising a package, if you're having to do this, or then obviously you're already talking about adaptations. Do you task shift? Do you make it into community level care? Do you shift it so it's only available at the hospital? Do you change the modality? Do you have a temporary structure or a mobile clinic that instead of going 3 times a week now goes once a week or twice a week? Do you change your treatment protocols because you don't have the medicines, or you don't have the ability, or you don't have the lab diagnostics? Do you change all of that? Do you do task shifting? Looking at the resources required, partner capacity, can it be shared with other partners? Can you have one common medical supply route in? Can you share health information and costing? What are the resources that are required around that? And any potential impact on the community, including trust. So services to maintain, very simple. You can carry on without change. Services to adapt, like we've said, adaptations. But services to suspend, what are you doing there? What are the referral pathways available? Can we transition to other care? All those questions on where do communities continue to get care? And importantly, beyond suspension, populations will still have health needs. So that still needs to be monitored, because those health risks, those threats, risks and needs may increase the longer we have a suspension of services. Okay, so next steps within that have been put within this, communicate with your communities, obviously, as we've said, also in the design process, the choices, the options, but just very simply, so they know where they can access care. Who are they going to go to? And this is the role of the subnational, especially cluster coordinators, to work with ministries to do that mapping and understand, and being able to say, okay, and we expect partners to work with the clusters to say, we are closing, this is how we're handing over. That other partner now has a catchment population, it's jumped from 10,000 to 20,000. Supporting healthcare workers, oh my gosh, I can't see. Sorry, monitoring impact, making sure you've got advocacy as we have those unmet needs, and then where possible, trigger a review of whatever your package is, or whatever your prioritization is. Okay, so that was really around services, which may to some extent be relevant, but you're reprioritizing your HRPs anyway. But it's a question when you do this, and I know Mukesh from South Sudan was asking, what is the hyper minimum package? Do we prioritize groups in populations? Do we just do child and maternal health care? Will that help? Cost reduction. Cost reduction usually is around HR. 70% of costs is around staff, and then medicines. Will the provider who's absorbing, who you've handed over to, do they need to prioritize services? Maybe they can't do the full spectrum. Maybe they need to cut down and say they need to do other things. So I've got what support do you need here? I guess my question to you and everyone is thinking around those operationally. What prioritization? We've got 4 minutes, which isn't much, but we're willing to stay over for those who wish to. It's a candid conversation. We're definitely here for another half an hour. You guys can drop off whenever you want, but it'd be good to know from you what prioritization challenges you're facing right now. It may not have hit you yet. It may have hit you. I know some contexts aren't really talking about or thinking about this yet because they're not so impacted. But any thoughts or feedback to share with our cluster family on this?
Iba, also there's a question from Sami on if we are tracking top-ups, funding top-ups by country.
I'm not sure what funding top-ups mean. If you mean CBPF and SURF, definitely we do that. The SURF allocation, the priority country was actually Sudan. A third of it is going to Sudan. Andrea, hands up. Hello.
Hello, good almost afternoon, everyone. So in the context of OPT, I believe, so for 2025, the response plan is a flash appeal, and the prioritization exercise is not taking place over here in terms of service delivery. However, given the 42 days of the ceasefire, there was a 60-day ceasefire plan that allowed for expansion of services compared to the previous 15 months or so. But now we're seeing a situation where, some of those services that may have been suspended, elective surgeries, etc., those have a massive backlog. And so along with the trigger to prioritize or scale down services, you also maybe have thresholds for times when you can have opportunities to scale back up and what those look like, because now those considerations also create a strain on an already very fragile health system. And obviously, Ministry of Health is keen to look at that and understanding how partners are now able to support that, yes or no. Does it fall in humanitarian response plan? Does it move into early recovery? Like, many questions around that, not a lot of answers, but I would just like to point that out as an example of the considerations that need to be made in terms of the service package, and linking it with the level to which services can be delivered in this precarious and fragile ceasefire time. Over.
Thank you. That's a great, and obvious, and thinking about it, kind of example. And when routine elective now creates a huge backlog, that hernia is not getting better. What do you do? It's now incarcerated. I mean, it's different if it's suddenly become an emergency, but there are other things. Absolutely. And the same with routine immunizations. As we saw a lot, it's suspended. When is that increasing the vulnerability to diphtheria outbreaks, which we haven't, or pertussis outbreaks, which we saw in Cox's Bazar, for example. Would anyone else like to comment or say? I mean, what do you guys need? Do you need anything at all? Do you need a commitment from partners to share openly, make sure they're working with you? And I'm sure people are going to say job contracts, and I'm not going to lie. That's not something we any of us in this room, well, maybe some of you are able to address, but are there thoughts? Okay, let me ask this. How are you finding your leadership in this and having to convene these? Are you facing these issues yet? Emiliano, if you're there, I'm going to ask you, because from the report that you gave and submitted, there's huge populations in Mozambique which are being affected by the suspension. And unfortunately, also populations which aren't in the HRP under the health cluster.
Exactly. Hello, everybody. I'm Emiliano, and health cluster coordinator in Mozambique. I don't know if you can hear me well. I'm on the phone, so maybe it's not the best connection. Okay, yeah, what I submitted, it's something that happened. It's more, we can say, the development side, but it affects everything, because basically there was this huge project, Proyecto Llegar, that with US funds, USAID funds, all the supply line of medical drugs for like one pays like 80% of all the ARV, all the HIV TB drugs. Then there's this other Gemonix ESM, it's called something like that makes the purchase from a lot of other drugs. That also, this one had some issues. I think it's being canceled also. Then there was this private company that was paid by VHA to do the transportation to the last mile to almost every health center. The health centers that they couldn't reach was basically those in conflict area or that were unreachable or had already some other process. At the beginning, it had the suspension in the 90 days, so they suspended the activities, and it was a bit quite messed up. And imagine that's a private company also, so they get the suspension. They started to fire some of the people. Then they managed to get the waiver for HIV drugs, but I understand they got in the system through the HIV program. No, but they transport all the drugs, basically, most of the drugs for all the health posts, especially those who are in the remote areas. They go to the district warehouse and then distribute.
Emiliano?
So with the waiver, yes.
Sorry, can I ask, how are you working with partners? How are you discussing and mapping this, or trying to keep abreast with it, or find solutions collectively?
Well, in this one, we have different things. As I mentioned, this cancel now is apparently, so they got again the contract, so they will restart. But we did start the meeting with all the partners, and in this case, with area coordination, we're working with the Secretaría Provincial de Salud, that would be the MSAU, the Ministry of Health here, and that's just now come from a meeting that we're asking each partner which transport line they can support. Of course, that's not a long-term solution. Actually, today I mentioned this possibly that apparently they resigned the contract and they will restart. But we already said, okay, yes, this is a very interesting alert also, because even if they have funds guaranteed now to January 2026, what's next? Because they're not going to appear most probably, and that's completely dependent on funds. So we have to start thinking of ways to really empower the local health system to be able to do their own jobs. So that we had a lot of discussions here in area level. The partners are trying to help as much as they can, because as mentioned, all the organizations have big issues. There's IOM yesterday already reduced like 60, 70 staff, a lot of them health staff. So every organization has quite big funds. Then I'm also addressing what at national level with the country office, we're also I'm passing all the information to try to talk to the different actors in the different levels. We're trying to push a lot that topic. Then we have all the other topics, different organizations. One issue I did have that it's quite difficult in general, the organizations either did not have clarity and did not know really, because of all this uncertainty, what was the effect. That's even, I think, valid for us in some part. And then another thing that I noticed a lot, especially UN agencies, they were more keen to try to share all the information and the wish to try to get funds from somewhere. So it was a bit trying to push a lot. I did a lot of phone calls, meetings, and I think a mixture of both, trying to not share the little information they have, and the other reality, I think that it's also true that most of the organizations still at the moment, I'm not completely sure. I think the agreement that we're all in big issues, big problems, to not say another more used word. But yeah, I think we're trying to have meetings. I'm trying to finish a report and share with the partners. All this in the middle of the projected crisis. Another cyclone that hit Sunday the country.
Yeah.
So the SURF allocation, they're also having some issues here with allocation that goes to the same partners like always. So we're having quite some discussions in that area.
Okay, that's great. But very tough. Michael, I'm going to ask you, because Emiliano from Mozambique highlighted, partners don't know, situation changes daily. 1 week you have one update, one week you have a different, and that's as expected. No one can really predict what's going to happen and where you're potentially going to find solutions. Michael, are you there? Are you there, Michael? Michael, we were talking on Sunday. Oh, I cannot hear you. He may have gone. Okay, well, I mean, Afghanistan are doing weekly updates and working with partners. They have gone from 300 health facilities on the 19th of February to 188 health facilities, which are now suspended or reduced services. And that's because somehow UNICEF and WHO found money for 1 month. And so we've got services for 1 month. But if you can imagine, that's exactly what a great example of working with partners to understand collectively what the impact is, where the solutions are. But this needs to be communicated to the communities, because if suddenly they've got their health facility open again, that's great. But if not, otherwise, and again, this goes back to the amazing work that all of you guys do, especially at subnational level, and that mapping of the services. I'm going to ask, and if people have got anything to say, you've got another commitment, that's great. Inviting anyone else to either share their experience of how they're working with partners, or any tough prioritization that they're having to do. Alain, Alain, are you online? Or anyone from Myanmar, because Sasha said my team are here, they will share experiences. So I'm going to ask anyone from Myanmar. Okay, it's all right, guys. It's 8 minutes past the hour. I think we've given you a lot of tips, questions that you're already doing. But the importance of these tools is that it was developed collectively with health cluster partners. So it's in essence an agreement of an understanding of how to deal or go through with prioritization exercises and with ethical dilemmas. So you're doing intuitively, probably already, as already described, but it's just important that there is a consensus around this. Maybe at the global level hasn't disseminated down. Every context, every village, every locality is different. But feel free to reach out to us with any other questions or anything that you are facing, challenges, or anything you think that's important for shared learning. Please do reach out to us. I'm going to close this. I'm going to say thank you to Andre, who didn't say anything, but is online and has been very involved with all of you previously. And also thanks to John, who is from the H3. And of course, thanks to Nurian to giving that clear partner perspective, but especially thanks to you all for your continued work. It's an open channel. If you need help, if you need to brainstorm, if you have got good practice, just flick it over to us in Teams or email, whatever it is. And as Nurian says, stay strong. And good luck to everyone. Okay, on that note, we will close. Mohammed Al-Hamidi, why didn't you speak? You can't clap at the end. It's okay. I'll let you off. It's fine. Okay, thank you, everyone. Oh, Elia.